what a delight to join you. Phil, Patty, Michael, the whole team that organized this, thank you for the opportunity to be here.
Thank you as well. I wanted to let you know that one of the greatest things that I love about Ireland is Guinness. And last night I asked for Guinness. Well, no, they don't have Guinness. But at the end of this session, I was told that we need to sing because they gave us a special provision to use these microphones. And I said, only if I have a Guinness. So hopefully that will come true. We're going to go into the session using the WHO public health approach, which is all of you know the model that has been in place, and we're going to focus on education, the implementation of services, and the outcomes of services. And we already talked about drug availability and medicine availability and policy. So what is the aim of this session? Well, we thought about that we need to reflect on how leadership, research, education, and practice can help meet the challenge to incorporate palliative care into national health systems, right? It's not about one single service, but we're talking about a country-level approach, a strategy that can help the WHO improve and also help the countries adopt the WHO resolution. And the goal of this session is to develop, the goal of the whole aim and what we're planning on is to develop in-country leaders to improve palliative care capacity. So that's the strategy. So we have 3 key messages that would like you to take home with you. The 3 are that everyone is a leader. This is not the thing that, some people are born leaders and, the rest of us are doomed. No, that's not true. All of us have either are already leaders or we're getting there. But we can all be leaders. Everyone is a teacher as well. And we have different types and different forms of teaching, but everybody can become a very successful teacher. And everyone is also a change agent at different levels, either at the local, national, regional, international level.
And you might say, well, that's just the group of us in this room. But in fact, if you think of a healthcare team, and you think about the nurse case manager who goes out to build the patient family care team, doesn't that person need to be a leader, a teacher, and a change agent? And so does the social worker, and the spiritual counselor, and the physician. So these are broadly held skills that we need to teach. How many of you had leadership training at some point during your educational experience? Very small number. Well, more hands going up. Okay, great. Perfect. So broadly holding the concepts for all of us.
So we have a mandate, and we looked at the resolution, and we looked what does the resolution says about education and research, which are the topics of this session. And basically, we summarized them in these points. On education and training, the resolution is asking the governments to implement the steps to take improve education at the basic level, at the intermediate, and the specialist. And what happens in the countries, as we all know, is that most of the services are specialized. So we need to bring these down and make it available, both at the intermediate and the community level. The quality improvement strategies, which is actually development systems to collect data collection systems, right? To how do you measure if what you're doing is having an impact on the patients that you're caring for or the people that you're working for. And then on research, the models on palliative care that are effective in low and middle income countries. It's not about high resource settings, but how can we help those countries that have less resources implement the strategies to do effective research so that that research turns into changes in policy and practice. Not just a paper that is published, hopefully that's part of it, but hopefully that also will result in policy, in changes in policy.
So we need to be transformers, don't we? Transforming every aspect of what's happening in our communities. And I like to say, isn't palliative care really the next tsunami wave of organized medicine? Our need is there because we've been successful in medicine. Now, how do we take it that next step? So let's think about a brief model. What are the stepping stones? You can't do all this overnight, can you? we need to start to build initial capacity in a country. In fact, I'm going to suggest to create 1 or 2 models. Most likely to achieve that, it's going to need to be some help from outsiders in terms of a particular country, some external facilitation. If there's people in country who can do it, that's terrific. First of all, we need to look for national champions, people who can actually lead this process, who have awareness and are skilled. And we may even need to train those people. We then need to look for clinical champions, people who will be the leaders of the process. And I don't just mean doctors, I mean, could be any member of the team. They need to get skilled. We need to build initial services that are the models, and we need to develop some initial measures to look at our effectiveness of even these programs. Then once we have the model programs in place, we need to think about how can we multiply this inside the country, develop a process for facilitation from within the country to build more services, teach more people, and enhance the measures. And we begin to look at a cascade of services that are developing, not one, but a whole series. So we begin to look at the population-based stepping stones, don't we? Let's start off by focusing at the top, break this down in a bit more detail.
So we start initially by finding and developing the skills of those national champions. And when we think about national champions, they can be either clinicians, politicians, regulators, but we want somebody who's able to influence policy and systems change in their countries. So think about how can we develop that person, or how can we help identify that person and then help develop that champion? Is there an existing leader to get the process going? Do you know anybody? Is it yourself who can do this role? And then is that person positioned to manage the resistance to change that you will have in the countries? How is this person going to react to those questions, let's say, from the Ministry of Finance, when he or she will say, we don't have funds to implement this program, palliative care in the healthcare system? So is that person capable of responding and taking the steps to just build on that resistance and see how can you make the bridges and make things happen?
Of course, nobody in the room's ever faced resistance, right? So one of our questions is, which just goes beyond the series of questions we'll vote on at the end, what are the characteristics of an effective champion who is positioned to facilitate palliative care service development and manage resistance to change? Well, there are actually some models out there of who actually potentially is an effective leader. We can't highlight them all, but one of the pieces that we like to bring forward is the work of Kouzes and Posner, who actually looked at the characteristics of admired leaders, and what's highlighted in pink are the top ones on the list: competent, forward-looking, honest, and inspiring. This is the most researched paradigm of leadership skill development. And I think it's useful, if you haven't become aware of the Leadership Challenge by Kouzes and Posner, it's very important to investigate it. It's a fabulous framework.
So just a point, this study, it was actually implemented in, I think it was across more than 20 countries.
Yes.
So this data does not reflect just a single country, but different countries in different social and economic levels.
And languages.
And languages, yes.
There are other models we'd like to share with you, but for time's sake, we're going to move on to simply say it's important to think about the characteristics of the people you're starting with. And then we need to find and skill clinical champions, don't we?
So we start with the basic skills of all healthcare professionals. How do we do that? How can we incorporate and implement strategies so that not just the physicians, but all the nurses, the pharmacists, all the allied care professionals do know the basics of palliative care? What are the essential components of a palliative care? What can anybody know at the community level to identify a patient with a palliative care need? And then are they capable of treating and managing the palliative care needs and symptoms of that person, or refer to the appropriate level? We also need to work with the intermediate level and then the intermediate skills of those professionals like oncology, pediatrics, geriatrics, internal medicine, psychiatry. And specialty skills for special palliative care physicians, for physicians trained with a subspecialty in palliative care, or consultants and teams who are able to respond to those calls for needs. And then we also need to work, go ahead.
Well, I was going to say, and given that what we're trying to do is develop a model here, where are we likely going to focus? Probably first off with specialty skills, because we want a model program that's capable of then multiplying inside the country. And I didn't say model inpatient, I didn't say model home care. It's going to be based on what's appropriate for the setting, the situation, and the opportunities. So, first of all, we're going to need to model to guide palliative care, aren't we? What are the components we're trying to address to help patients and families have a different experience?
So we have to think about what are the needs of the palliative care patient and the family as a core group, where we know that it's an array of things that we need to address. We have the disease management with the diagnosis, prognosis management, and then we have the physical, we have the psychological, social, spiritual, practical, the end of life management, and also the loss, grief, plus the management of the team. So we have all these things that we need to think of, and not just about one single component, which is usually what we're focusing on, which is the physical. Think about all the palliative care needs as a whole person, and then how are we going to help build that?
And of course, we need to respond with a process. How are we going to approach assessment, information sharing, easy and difficult decision making, care planning, care delivery, and are we going to stop and ask, not just with your hand on the door for the caregiver, how are you doing, but are we actually going to do some confirmation about, was the process understood, acceptable, are they happy with the next step? And this is every visit. This is a part of it, but we need a model, norms of practice, guidelines to develop it. How many of you have, within the context of your country, a national approach and a model which is guiding all your programs? Hands up. So I see a couple. Hands maybe. And I think the issue is, if we don't all agree on what we're trying to do here, how are we going to create a model program that we can then multiply effectively across our country?
And one that the WHO could use.
One that WHO could use,
Right.
exactly.
So again, just going back to what I was saying before, this is a multidisciplinary approach. And we can think of a core team that in some countries, there's not a lot of resources, so we have to probably think about a physician and a nurse. But then how are you going to provide for the resources to meet the other needs of the patients and the caregivers and the family? Do you have the team to provide psychological and emotional support when anxiety comes up? Do you have the spiritual person, the spiritual caregiver? So all those resources have to be part of your strategic plan to develop the team.
And you might not agree with the model we put up. The roots of this are the Canadian norms of practice, the model to guide hospice palliative care, adapted in Spain, translated. But the important thing is for you to have a model and have a concept behind it. So then how do we identify clinical champions or clinicians who may be prepared to focus their career or build their career on palliative care delivery? Becomes a real question, doesn't it?
May I ask a question? Was it for you a decision that you decided to go into palliative care, something that it was since you were babies, or was it something that it took a long time to decide? Think about that. How do you make this happen? How do you make people do what you're doing right now? How do you inspire those that are following?
So what are the stepping stones? Imagine we're going into a country where nobody even is aware of palliative care. Are there any countries like that you've met? I see lots of heads nodding. Yes. So first of all, recognize this is a multi-year process. This doesn't happen overnight. And in fact, my experience of working in several countries is this is a 10+ year process, maybe 20. If I look at the experience in the United States, we're still doing it. It's still ongoing. So this takes time. Often starts off with sensitization type programs. It's the talking head. Frank Ferris gets invited to the cancer conference in such and such a place, gives a talk, and a few people say, oh, this is a really interesting idea. Awareness starts to grow. Somebody might say to me, oh, well, will you come back and run a small course for us? We've got some people who are interested, and we start off with a basic, maybe 3-day, 2-day, 4-day, depending on how much time people can spend, course, which is the basics of palliative care. We don't need to get out the fire hose and hit everybody with every topic because we know they won't remember it. It's just giving a taster, and the major purpose is increasing awareness, changing attitudes, and a few key messages that people take home, not more than that. Those who are interested might come back and do an advanced program, but it still may actually take an advanced course to get people's interest up. I like to say when I go into a country, it's like a fresh bottle of milk. I shake it, and I wait to see who's actually going to rise into the cream layer. How many people who go to courses in low and middle income countries are actually tapped on the shoulder and told, you need to go to this course because somebody invited them, and they're saying, palliative what? Oh, palliative, oh my gosh, no, I don't want to do care of the dying. And they actually disappear after the course. We've been having a whole conversation about that in our discussions, haven't we? So once they rise into the cream layer, well, that's a basic course, an advanced course, but are they really serious? What I found very useful is to give people an opportunity who express interest to actually have an experience in a program providing palliative care. For me, it was a visiting scholars program, a 4-week opportunity for people to see it and try it, and even some of them ran away afterwards. But if they're really serious, then we move on to specialist skill development, don't we? And of course, there's many different models for doing this, but my point is, it's a cascade. Jane Dixon published a lovely paper back in 1978 about the goals of education. And I think it's super important for us to have a framework. I've used this in all of our curricular materials. The most difficult step here is the first one: increasing awareness and changing attitudes. In the classroom, we can give people some knowledge. We can barely build skills through small group, case-based discussions and role plays, but skills actually happen at the bedside. And then what we know is that people don't necessarily change their behaviors at all. We actually need to mentor them in classroom-based and bedside training to change behaviors. What we're trying to do is change the patient and family experience, so we should have measures at that level. And we're trying to change the experience of the host organization and the society. It's our population-based issues. We should have measures at those levels. Are we actually doing something useful? So this is a great framework guiding education. And smile sheets at the end of a conference are no longer enough.
Right.
Are you changing behavior? And are people going out and practicing? And what are they actually doing? Are they referring? I love Scott's piece. The generalist, are they actually referring more patients earlier? Let's track the doctors, the nurses, the people who are in the courses, and ask them about their behaviors. That's the new education outcome measures.
So usually the model that you see, and it's changing in high resource settings, but still in low and middle income countries, the teaching model is very passive. So you can have a palliative care conference, so you can have a palliative care professor flown in from with all the degrees, gives a conference, everybody nods, everybody thinks it's fantastic, and nothing happens, and a lot of money has been spent. So let's think about models that really incorporate changes in behavior so you can have the changes that we want to see at the patient care level.
And what do we know about retention? So here we've all sat here for 2 days. What do we know about retention from a didactic presentation at the end of the conference? How much of the material is retained? Does anybody know? No, it's not even 20, it's 10%. If we move on to small group case-based discussion, it goes up to 25%. If we move on to role plays, it goes up to 35%. If we don't use it, we lose it. And I'll show you the data, in fact, from one of our programs.
It's not even promising for our presentation here.
I know, it's exactly, it's what's your take home from us even, right? So we need to provide all kinds of styles. We need to make it very interactive. We need to take real people with real mentors to the bedside. A great example was in my very first course in Jordan and Amman. This young gentleman, over the first week in the program, did beautifully with answering all the paper models. And here we had our first oral morphine for the course. This lady had been in bed and not sitting up for 5 to 6 weeks. I said, great, we've got some morphine, would you prescribe it? I got out my pen, I handed it to him. His hand started to shake, and he said, no, I won't do it, you do it. He wouldn't write the prescription, even after 5 days in the classroom. He was terrified. I've seen it time and time again. So I wrote it, but I said, I can't sign it. You have to sign it. I don't have any license here. So we signed it. The nurses were all horrified. The pharmacists thought we were killing people. That's the truth. That was really a big deal because the pharmacists weren't in the course. They really resisted. We came back the next morning. She was sitting eating breakfast. A couple of days later, she said she can go home. Asked if she could go home. She was feeling much better, thank you very much. Of course, his jaw was, wow. Patient in the bed over there said, that must have been some good stuff. Can I have some of that too, please?
And it wasn't Guinness.
And it wasn't Guinness, no. He went on to become a palliative medicine consultant, is now working in Saudi Arabia, running a home management team. But it took the modeling to get there. And what do we know? So I had the opportunity to compare a couple of courses that were 1 week in duration with a couple of courses that were 3 weeks in duration and actually look at the data, even on knowledge competence testing. And what I could see in knowledge, if you look at the red, it's the 1 week course, went up a small amount compared to the bedside training program, which was 3 weeks in duration. Significant data. And then the question was, well, how does that compare with other models? We actually had similar data using the same tools in the US, and these are the 1 week and 3 week programs compared to first year postgraduate, second year, third year, fourth year, and US faculty getting very similar courses. You can see the folks with the 1 week, yeah, they do so-so, but the folks with 3 week actually are pretty much up there. And those are folks who weren't necessarily postgraduate in the same way. So we can do a lot, but what about the repeaters? So we actually brought people back. What do you see? So the 3 week course in blue, the folks then come back a year later. What do you see about their starting point? They've lost a lot, haven't they? They've in fact not retained significant amounts, and this is pre-course testing, but they actually go up a little higher with the repetition, and we see its significance. And what's very interesting is if we ask people to rate competence, at the beginning they say, well, I know a fair bit of this. And then if at the end you ask them to rate, well, what did you come in with? And they say, retro, they say, oops, I didn't know what I didn't know, did I? People think they know this, but they don't, but this is self-rating of competence. And what was most interesting was to say, again, we've shaken the bottle of milk in Jordan. One physician wrote during the first week in the classroom, so it was a 5-day classroom, followed by 2 weeks of bedside, I felt that I will not benefit, and it will not do any change in my practice. He said, but after starting the practical session, a huge and unexpected change occurred, or happened. I will do every effort I have to practice this knowledge in my real life. And Dr. Mohammed Bushnak floated up in the cream layer and is now a palliative medicine consultant, busy practicing, running his own NGO in Jordan, and being very active within the context of the region. Our first person to specialize in our international fellowship program.
So to build initial capacity then, we have to think about how can we find the resources and where do we find the resources to support that initial program development. And then we're going to need funding, right? And then we're going to need the administrative support to make it happen. And it is always very nice to dream about programs and hospices and I want to do this, I want to do this. And usually people just launch in without a strategy and without a plan and without the funding. And what happens? A year after, you're burnt out because you're working 48 hours a day. It doesn't have, it's like crazy. And you don't have the funding and everybody's burnt out. So you need to plan ahead and think, how are we going to make this happen?
And recognize that as we begin service development, it's got 3 opportunities for every team. Because we're always working in servitude to someone who made the referral, as Scott points out so beautifully. Somebody refers the patient to us. There's an opportunity for direct patient-family care, and we need to very carefully learn consultation etiquette because we want that doctor to refer lots more. There's an opportunity for education. Every consult is an opportunity for one pearl. The busy doctor, the busy nurse, the social worker, the spiritual counselor, they can learn one thing at a time. It can take 1 minute. And there's also an opportunity for us to ask the staff, how are you doing? Because we can begin to recognize compassion fatigue and burnout. It's very high in our system. People who are stressed and seeing lots and lots of patients, we can become part of the solution for the host organization in which we're working. So where do we start? Maybe you'll start in a hospital. Maybe you'll start building a specialty unit. Maybe you'll start in an ambulatory outpatient. Maybe you'll start in home care. Maybe you'll start in a care home, in long-term care. It depends on the situation, the feasibility, and the opportunities. Each one of you will make choices based on a really good situation analysis, won't you? That's going to be the first step.
Right.
And then start small, 1 program or 2, and plan for growth. How many of you have been in the situation of, oh, well, we're going to get started here, and a year later you're saying, I am burned out. I've got so many patients coming at me, I don't know what to do, but I didn't plan for new staff to come along. That was certainly my personal experience. At 18 months into this, starting a home-based palliative care consult service, we were overwhelmed, and we didn't have the plan, and we didn't have the resources. Plan for success, pre-negotiate the resources. Be careful what you wish for. You're going to get it.
So you have to start collecting data in order to demonstrate that what you're doing is useful and is making a change, both at the patient level and then hopefully at the institutional and the national level. And you're going to have to start thinking about the quality of the care and the service that you're doing and you're providing and any other things that you're setting up, like an educational program. How are you going to measure the success and the process that you're doing here? And you may already have noticed that this presentation is about process. It's not about models. And what we want to stress here is that in order for you to succeed, you have to think about the process. Trust the process, because if you have already a plan, it will get you where you want to go. But if you're just walking to point B, it's not going to get you there if you don't have a plan on a step-by-step approach.
Well, it's beautiful what Liliana is saying, because we even heard in one of the model presentations, in spite of the leadership changing because there was a strong vision, the program continued to grow. Do we have a carefully thought out strategic and business plan behind this, and we're projecting success? So the next question is the one of, well, value. And I raised this yesterday briefly. The question is, how can palliative care service clinicians and managers, so all members of the team, establish what is most valued by the host organization and what to measure to demonstrate their value? So many of us will build a service inside an existing organization. We're there to help them be successful, aren't we? I say we're there to help them look good, feel good, and smell good. That's what I always say. And I say that particularly about the referring clinician, because it could be a nurse who refers, it could be a social worker who makes the referral. I'm responsible. It's part of consultation etiquette. So how do we do that? Well, value is quality over cost. We talked about both yesterday, so as though they were independent. They're not, and there's also the issue of safety, which we really think about as minimizing risk, but also it's don't do therapy that doesn't have any benefit. And how can we actually participate in data collection to look at this? Well, we do have some papers that drive us towards this. Here's the Temmel study published in 2010, showing us, to our surprise, looking for quality of care, lovely randomized study. Oh my goodness, these patients who got early palliative care lived longer. Surprise, and Betty Farrell in City of Hope, I understand, has just repeated it and showed a longer survival.
So may I, just one thing going back to the previous slide about how can we build things to make the institutions look better. Do you have a conversation with the hospital director? Did you have that conversation of doing, one-to-one saying, how can we make this hospital look better? It's always about our service and our needs and what we want to do, right? And then we have sometimes those tensions, but if we don't negotiate sometimes and sit down and have that conversation with the hospital director, then maybe there's a point that both of us can meet, and then it will be a win-win for everybody. I don't know if that's clear, but that's something that we want to stress.
Well, and if an oncologist, for example, because this is non-small cell lung cancer, is wanting to do the best for their patient in terms of disease management, can we tell them we're on their team to help them? Sure, it's not just about quality, it's about we can help you with your survival. Don't miss the opportunity to merge the two ideas. You might do it, Dr. Oncologist. You might build these skills yourself as part of the intermediate level skills. It doesn't have to be us, but don't miss the opportunity for your patients to get the best. Lovely study done by Equidamus in Kaiser showing that we can actually reduce hospital readmission rates, and that in fact this was done in a setting where we have the enhanced palliative care called hospice care in our setting, which is an insurance benefit. And you could see if patients were on enhanced palliative care or seen by home-based palliative care, they had the lowest readmission rates. What's the data in your setting? Do you have the data? Joan Tino published a spectacular study. This was an after-death survey of family members looking at the question of where did your loved one get the best possible care. It's a great randomized study from across the country. Look which setting had the best care. Hospice or enhanced palliative care. She drilled down on it a little further. This was published in 2004, so it's 11 years old, this data. Are you all using it? And she said, well, did people want more pain relief? Did they want more physician contact? Did they feel like they got no respect? Which is the place where they wanted most physician contact? And where would you go to find a doctor in your community? When you go into a hospital, and yet they said they didn't get contact. Again, what's the winner? Enhanced palliative care, the hospice benefit. Also looking at finances, and I know there are many papers out there, and there's variability based on the funding models. Again, in our setting, this works, showing in a lovely paper in Health Affairs in 2013, significant savings by patients having 50 to 30 days on enhanced palliative care. Again, do you have the data in your setting? So, as I put this together, and I'm being very simple, I start to paint the picture, don't I? Enhanced palliative care provides great quality, reduced cost. It is the highest value for patients at the end of life. Why are we making this an option in our healthcare systems? Stop making referral to palliative care a choice. It should be, if you want the best, sell it that way to the leaders, and make sure that the number of referrals to enhanced palliative care are actually a measure in the host organization and their quality indicators. In our setting at Ohio Health, we've now achieved that. So they're looking at number of referrals to palliative care and number of referrals to hospice care, our enhanced palliative care benefit. Again, walk them towards it so they're now measuring their own success, and congratulate them when they are successful.
So the data collection process, we have to start from the basics to a more complex data collection system over time. And let's think about the structure, process, which leads to outputs, and then impact, which leads to outcomes. We usually think about sometimes of process indicators, like how many patients we see per year, how many patients were referred to the palliative care services. But are actually those patients now better? Do they do they have good quality control symptoms? Do they have good quality control of all the needs, or do they have the palliative care assistance and spiritual support that they needed? Are you measuring that, or are you just measuring sometimes just the process? How can we make this happen to show that what we're doing is actually improving the life and the quality of care that we're providing?
So let's move on to the next step, the multiply. Let's assume we've got a model program in place, the clinicians are trained, they're prepared to start to roll this out and share it with others. What are the next steps?
So we have to work on the internal facilitation, which is actually inside your countries, right? We're thinking of a national system right now because we're within the WHO agenda. And then how can we teach others out of our program? How can this program that has incorporated all these elements that we addressed, how can it become sort of like a center of excellence and become a role as a model to the rest of the other centers? How can we build more services? How can we increase those legs of the cascade that Frank has beautifully put up there? And how can we enhance the data collection systems that we are doing? Not just numbers, but are we actually measuring quality?
And although we might have started off with core measures for that first program or two, do we now move to host measures and a more enhanced measurement system, or do we move to what I believe is the desirable? So imagine this as a country. We've got 8 programs there. Are they all collecting the same data? And are we starting to be able to look at population-based impact? Again, we may not be able to do that the first day in detail, but by the time we get into the multiplication, we should be moving on to that step.
So to multiply, what do we have to do? We need to educate others, right? We can't hold this onto ourselves. We can't hold it onto our own institutions or associations. We have to make this a massive wave of palliative care education for everybody. Put it into the undergraduate levels. This is the way and the strategy to do it. Then we need to develop the leadership skills of the people who are going to be those teachers. How are we going to do that then? Find the additional resources and the funding we need, and the teachers we need, and the role models that they need to follow, and build more service capacity so that the cascade can multiply throughout the country. Think about your own countries and examples and what has happened. Is the situation the same as it was 15 years ago or 20 years ago? Have services expanded? And what was the way to get there?
And as we think about even the more resources, well, we might have started off with a philanthropy-based model with donors. How many philanthropists stay around with us for 20, 30, 40 years? They don't, do they? They withdraw. So to get to that next step, have we actually embedded this into the funding models that exist within the country for providing services? Don't outbuild in your philanthropy process and overbuild something that then can't be sustained because the resources aren't there. It's got to be very situational, contextual, and feasible, because you'll be disappointed. So as we move on to the educate others, how could palliative care service providers most effectively educate primary care providers, here we are, Scott, so they have the skills and competencies to manage and refer their patients when appropriate? Well, we just heard that in detail, didn't we? What a great presentation. And now we start to look at focusing on the 2 earlier groups. Well, we might have done some sensitization for them. Now it's time to really launch an in-depth education program to build that capacity based on the clinical champions and the people leading the program.
So we have to think about how can we do that kind of education and who is going to be the target group. And we have to think about the practicing clinicians and trainees that we're currently working with and those in other services. And what are the other tribes that we need to include? We need to think about the oncologists, the cardiologists, neurology, renal specialists, who all those tribes of people that work with patients who have palliative care needs. How are we going to engage with them? And then the community healthcare workers and the caregivers and the family members. Other people in the community that we also need to work with. We heard about the community model in Kerala. So other sources and resources in the community that we need to tap on and harvest from to do this massive education, both at the community and at the, also at the formal level.
And I would point out, it was commented about the fact that physicians go to education design for physicians. I would also suggest the cardiologists only go to education design for cardiologists. Geriatricians only go to education design for geriatricians. They show up at their conferences. How are you going to find a champion from within each tribe to move the process forward? And most importantly for trainees, if it's not on the exam, they don't study it. The oncology movement has created a presence where 10% of the questions on the medical oncology exam in the United States are now about palliative care. Guess what? Every fellowship program wants training in palliative care. It's just happened, and it was the driver of, if I've got to study it and I got to respond to it, I better know how to do it. So make sure it's a part of that. And the question is, what motivates change and resistance? And Liliana has a lovely change story to share with us briefly. And Liliana, just noticed we got the yellow light.
Okay, so very briefly, I want to tell you what we did in Colombia last year. And we work with universities, and we had, when you come to the faculty members, you talk to the deans, and you say, we want to do palliative care in the curriculum. They usually look at you and say, we don't have space. So instead of doing that, what we did is we said, can we have a talk about palliative care with your students? Bring your students from the 5th and 6th year from nursing and medical schools. And this is at the University the Ibagué in Lima, in Colombia. And we had about 300 students and all the faculty sitting in front, right? And the dean is that man standing against the wall. So we started posing questions about palliative care, hypothetical cases. What would you do about this and this? And the students were in a roar. They said, we don't know how to manage pain. We don't know how to do this. I have no idea that this existed. And you could see the faculty people just going lower and lower in the seats. And that was the most amazing force and driver to make that change happen. So we had a workshop after that, about 6 months after that, and we invited the deans and the curriculum officers of 18 medical schools. 36 people came, and they agreed on the consensus-based process with palliative care providers on what are the competencies for undergraduate palliative care nurses and physicians in the country. And that paper will be published in a few weeks. It's open access, and you will have access to the recommendations. And the idea is, what I really want to stress here is not about the paper, but it's about the process. I really stress that if we bring curriculum that was built in Europe or anywhere else down to South America, Africa, you name it, it's not going to work. You have to enable the people and facilitate the process so that they come up with their own agendas and they have ownership of whatever it's built. And then you can guide the process, and you can provide the tools, and you can provide the resources and the information, but then they have to do it.
So again, who's going to lead all of this? Does that person have skills? Can they manage consensus? Can they instill change? And can they manage resistance? Most likely, we're going to need to provide leadership skill training for the clinicians, the champions who rise and really say, I want to take this forward in my country. And that's going to be essential. And I saw not many hands go up when we said, have you had leadership training? Kouzes and Posner says, this is the art of mobilizing others to want to struggle for shared aspirations. I want to be on the team. I want to move forward. It's an observed set of skills and abilities. A leader without followers is simply a person going on a walk. Which path are you going down? Nobody's coming. What should I focus on to become an effective leader? Many people resist the fact that I've got to start with myself. And so leadership training is not about jumping in with strategic planning. It's about understanding self, our preferences, the way we like to learn, the way we interrelate with other people, other people's preferences, and being sensitive to this. It's an art. We become skilled at our intelligence, a variety of different activities, and then we move on. Hopefully, and I love this framework, getting to the place where the exemplary leaders are very skilled at modeling the way, inspiring a shared vision in the whole group, challenging the process, enabling to others to act, and most importantly, and I think we miss this so much, encouraging the heart, is turning around to somebody and saying, and I do this with my assistant all the time, Cindy, that was so wonderful what you did today. This is what it did for me and the impact it has had. It takes me 10 seconds longer, and Cindy walks away on the Friday nights and goes, ooh, I actually did something useful this week. How do I do that with everybody? So how can we build that program? There are 3 great examples of leadership programs. We had the opportunity to participate, thank you very much to the Open Society Foundations and the National Cancer Institute in the United States, to develop the Leadership Development Initiative. The full curriculum is open access on ipcrc.net if you wish to access it and download it. The European Palliative Care Academy, associated with Daniela, who's right here, the folks at the Bosch Foundation, is now engaged in their 2nd cohort, am I right? Of folks moving forward, and what a wonderful opportunity here in Europe. And within the American Academy of Hospice Palliative Medicine, they have a program for folks called LEAD. Fortunately, they don't make their curriculum public. They've kept it sort of proprietary, but at least there are 3 examples, and I think if we were to cuddle up beside them, they'd probably give us some of their pearls. The opportunities for us to grow leaders. With an LDI, this is the type of splash. Over our 2 cohorts, we've trained, and now 39 leaders are out there. You got to see Zippy yesterday. Wow, what a presentation. You got to see Daniela, who was one of our mentors. What a presentation. And there are others in the room who participated in helping us build and grow this and make this very different. And we all learned something in the process. I'm different because of this program. How will you implement this in your setting? And will WHO actually help you? It's a whole variety of different activities, and you can see some of the folks present. There's Kathy Foley, Joe Harford was part of this. You can see Eric Krakauer, see Zippy, Liliana's there, others. So, of course, our next step is to fully integrate, isn't it?
Yes. So think about the hospital, consultation, specialty palliative care units, ambulatory, outpatient, home care, long-term care, the different models that Frank mentioned a few minutes ago. And we start by integrating in one or several of them, but not the whole thing. As much as you can manage and as much as you can fund. And then they expand the research, recapping, developing the skilled researchers, and then enhancing the measures for the quality that you're providing, establishing a relevant research agenda with the models of palliative care effectiveness. Do we have a needs assessment? How are we going to develop our programs if we don't know who our target patients are? And then develop the funded projects. If we don't have the funding, we may just end up with nothing. Oh, we have a red light.
So, in summary, everyone's a
Right on
leader,
time.
everyone's a teacher, everyone's a change agent. Are you in your community teaching your clinicians leadership skills? One step at a time. Are you teaching people to be effective teachers so they know the skills, how to do case-based discussions, how to actually facilitate, do effective presentations, actually run role plays, and most importantly, how to be an effective mentor at the bedside, because you can see that's where the real change occurs. Yes, this costs resources, but if you think education is expensive, try ignorance.